Understanding medication overuse headache. A 35-year-old female presents with history of depression, anxiety, and episodic migraine headache without aura. She was referred to the neurology office due to daily recurring headache. The headache is described as unilateral, throbbing, and associated with nausea, vomiting, phonophobia, and photophobia. Patient reported that she has been taking rizatriptan more than 10 days per month, as well as ibuprofen for 15 days per month for the past 4 months. She's not taking preventive medications. Patient denies other symptoms like fever, weight loss, or focal weakness. Patient has normal non-focal neurological exam without papilledema. Medication overuse headache is classified as a secondary headache according to the 3rd edition of the International Classification of Headache Disorders and is identified by A. Headache occurring more than 15 days per month in a patient with pre-existing headache disorder. B. Regular overuse for more than 3 months of one or more drugs that can be taken for acute and/or symptomatic treatment of headache. 1. Simple analgesics like acetaminophen and NSAID for more than 15 days per month. 2. Triptans, ergotamine, combined analgesic medications or opioid for more than 10 days per month. C. Not better accounted for by another ICHD-3 diagnosis. The prevalence of medication overuse headache is 1 to 2% in the general population. However, it is higher in patients with primary headache disorders like migraine and/or tension-type headache. Risk factors for developing medication overuse headache are female gender, psychiatric comorbidities, other pain disorder like musculoskeletal pain, smoking, and physical inactivity. The clinical presentation of medication overuse headache depends on the primary headache phenotype. For example, patients with migraine headache report a migraine-like headache with increase in frequency. The underlying mechanism of medication overuse headache is not fully understood. Functional MRI patterns show hypoactivation of the right supramarginal gyrus, the right inferior and superior parietal cortex prior to medication withdrawal, and recovery to normal 6 months after withdrawal. Prevention of medication overuse headache starts with patients, primary care providers, and pharmacy education and counseling. Patients should keep a headache diary and report if acute treatment medication is used. Healthcare providers should identify patients with risk factors that lead to increased medication overuse headache and follow them closely. Treatment begins with educating the patient about the risk of medication overuse headache and then explaining the benefits of limiting acute medication for headache to less than 10 days per month for triptans, combined analgesia, opioid, and ergotamine, and less than 15 days per month for simple analgesia like acetaminophen and NSAIDs. Opioid should be avoided in most patients with headache disorders. Symptoms may resolve in some patients upon stopping medications. However, some patients may notice an increase in their symptoms before they improve. On the other hand, others may need detoxification or drug cessation plans and require preventive pharmacological and non-pharmacological approaches, cognitive behavioral therapy, biofeedback, etc. Randomized clinical trials support the use of calcitonin gene-related peptide monoclonal antibodies, topiramate or onabotulinum toxin A as a preventive treatment in such cases. Inpatients detoxification is recommended in cases with psychiatric comorbidities, history of substance abuse, and opioid overuse. In summary, Medication overuse headache is a common problem. Counseling your patients about the importance of limiting the use of acute treatment is crucial to prevent medication overuse headache. For more information on medication overuse headache diagnosis and treatment, please see the course resources